Yes, it's perfectly timed. Hello and welcome everyone to today's episode of Oral Pathology Tuesdays with Oral Pathology India. It's a great pleasure to have everyone here. And of course, it's a great pleasure to have Dr. Nandini with us today. Dr. Nandini DB, who is the professor and head of the Department of Oral Pathology at Dental College Regional Institute of Medical Sciences, Imphal. And of course, we also have Dr. Bhavna with us, and she is helping us with everything on YouTube. It's a great pleasure to have you here. Hi, Nandini. Hi, Bhavna.
Thank you so much, ma'am. Thank you so much for supporting and as always.
Yes, thank you. Today's talk is going to be about pediatric tumors. Now, we all know pediatric tumors are very difficult. For one, they happen, although they are rare. And when they happen, they should get all the same importance that any other tumor gets. But sadly, there is a scarcity of information on these tumors. And especially when we think of the fact that the ones in our region of the maxillofacial region are even fewer than the ones all over the body. So some years back, I think in 2012, Dr. Nandini, at that time we were working together. And at that time itself, she said she's interested, and everyone was picking up a topic, and she chose to pick up pediatric tumors and pediatric oral pathology. At that time itself, I knew it had the very right hands, and she would do great justice to it. She's proven that by working on it for so many years. She's come out with publications, which she's given talks on the topic. And today she's here to discuss with us the differences that exist so that we can be helped along in diagnosing these tumors uh, when they happen, because otherwise we have very little information on them. So with that short introduction, I will ask Dr. Nandini to take over, please.
Thank you so much for your kind words and encouragement, ma'am. It has been always very nice to be with you, associated with you. Thank you so much for this opportunity. With that, shall I begin with the presentation? Before I begin, I would like to say good morning to everyone and a warm welcome from Dental College Regional Institute of Medical Sciences in Manipur, India. The topic of my presentation today is distinct pediatric neoplasms, distinct biological entities. Before I start, I would like to tell that this presentation basically gives you an overview of the risk factors, the clinical presentation, and the differences between the pediatric neoplasms as well as the adult neoplasms. However, I shall not be going into detail about the individual lesions and their histopathology or etiology. If you have any doubts or comments or suggestions for improvement, I've shared my email here. Kindly you can get in touch with me. So childhood cancer is a relatively rare disease and the incidence is 1 to 10%. And of them, neoplasms occurring in the head and neck are only 2.5 to 5%. And about 10% of childhood deaths occur due to pediatric neoplasms, and it is the most common disease-related death in children 1 to 15 years. And it is the second common overall, second common cause after accidents. These pediatric neoplasms cause adverse effects on the developing structures in a child due to the disease process as well as treatment. Every year, an estimated of 215 lakh cancers are diagnosed in children younger than 15 years, and about 85,000 cancers are diagnosed in 15 to 19 years. And as of now, the pediatric mortality rate has gone down for infections and malnutrition, everything. But as such, the pediatric cancer has not taken much attention. But now, International Agency for Research on Cancer has joined hands with WHO for a global initiative for oral cancer. So the global initiative has a goal of reaching the survival rate of at least 60% for cancer, childhood cancer by 2030. So in the national scenario, based on the population-based cancer registries, it is noted that in India, the pediatric cancer is a ninth common cause for death in children aged 5 to 14 years. Every year, approximately 160,000 children are diagnosed with cancer, and eventually 90,000 will die every year. The overall survival rate, 5-year survival rate in the worldwide is around 80%, 80 to 84%. However, in India, it is still less, and accounting to only 37 to 40%. And the proportion, if you see the proportion, the cancers are more in males compared to the females. So this is the Indian scenario. Every year, International Childhood Cancer Day is celebrated on 15th February, while September is celebrated as Childhood Cancer Awareness Month. According to International Classification of Diseases of childhood cancer is categorized into 12 major groups, that is the leukemias, lymphomas, brain tumors, neuroblastomas, and sympathetic nervous system tumors, retinoblastomas, kidney, liver, and bone tumors, soft tissue and extraosseous sarcomas, gonadal and germ cell tumors, epithelial tumors, and other unspecified tumors. So in the Western world, you can see that the leukemia, Hodgkin's lymphomas, and CNS tumors, other lymphomas also, together constitute more than 60% of the total pediatric neoplasms, of which the leukemias top the chart, followed by the CNS tumors and the lymphomas in the Western world. However, in India, leukemia is followed by lymphomas and then the CNS tumors. When I did my undergraduation, post-graduation, there was no separate classification of pediatric oral pathology or neoplasms as such in the textbooks, and we were always taught about pediatric neoplasms under different headings. So here I had to classify pediatric neoplasms of the head and neck. We have published this previously as well, but a few further additions and modifications have been done in this classification. Most probably, the pediatric neoplasms are of benign variety and malignant are quite rare. Among them, I have classified them into those affecting the soft tissues and hard tissues. So here are those affecting the soft tissues, the hemangiomas, lymphomas, and other vascular tumors predominate, followed by mesenchymal tumors, the myxomas, fibromas, congenital granular cell neoplasms, and so on, and then the neurogenic tumors and the salivary gland tumors like pleomorphic adenoma, and other epithelial tumors like squamous papilloma and congenital uveitis. Among the malignant neoplasms, the leukemias, lymphomas top the chart, and among the mesenchymal tumors, rhabdomyosarcoma is the most common neoplasm affecting children, followed by various other sarcomas. And then among the neurogenic tumors, the neuroblastomas and CNS tumors predominate, followed by granular cell myoblastoma. Among the salivary glands, the mucoepidermoid carcinoma is the most common, followed by acinic adenoid cystic carcinomas, adenocarcinoma. Among the epithelial tumors, the squamous cell carcinoma, basal cell carcinoma, melanomas usually occur when they have a predisposition, familial predisposition. Then thyroid carcinomas and nasopharyngeal carcinomas also occur in this age group. When coming to the hard tissue neoplasms, the fibroosseous lesions, especially the fibrous dysplasia, juvenile ossificant fibroma, and cherubism, are seen commonly in children. Then odontogenic tumors such as cystic ameloblastoma, calcifying epithelial tumor, some reports are there. Then AOP and ameloblastic fibroma, fibrodentinoma, fibrodontoma, and odontoma. Now they have been clubbed together in the recent classification. Then the new entity, that is the primordial odontogenic tumor, has been added. Odontogenic fibroma, myxoma, and some neoplasms also occur in the pediatric age group. Among the malignant hard tissue neoplasms, osteosarcoma, pondylocarcinoma, and Ewing sarcoma are most common, and you may see rarely the malignant counterparts of the benign odontogenic tumors. Other miscellaneous tumors include teratoma and metastatic tumors from the other parts of the body. The risk factors are largely unknown. 75 to 90% are unknown in case of pediatric neoplasm, and 5 to 15% are attributed to familial predisposition and genetic factors, and 5 to 10% are attributed to environmental exposure and exogenous factors. Among the hereditary factors, familial neoplastic syndromes, congenital malformation and inborn errors, immunodeficiency associated aging, then age, gender, ethnicity, maternal factors are the various factors under genetic factors. And among environmental factors, ionizing radiation, UV radiation, therapeutic radiation, both diagnostic radiation, including immunoflow, all are attributed. Then electromagnetic radiation more than 60 hertz, infections like Epstein-Barr virus, human immunodeficiency virus, hepatitis B virus, human papillomavirus also play a role. Second-hand and third-hand environmental smoke, tobacco smoke. Smokeless tobacco has also caused many increasing incidents of cancer in children nowadays. Industrial and agricultural pollutants, chemicals, metals, plasticizers, diet such as aflatoxin in the diet or red processed meat, and obesity has also been indicated as one of the risk factors. Uh, all cancers are genetic in nature, but all are not inherited. Germline mutations, which occur in the egg or the sperm, are mostly heritable and they cause hereditary cancer syndromes, while the somatic mutations occur in non-germline tissues and are not inherited and they have a later onset. Here are a few examples for genetic syndromes. Familial neoplastic syndromes, for example, familial retinoblastoma has uh, caused due to mutation in this particular gene leads to retinoblastoma and osteosarcoma. Similarly, you have inherited immunodeficiency or bone marrow failure syndromes. For example, ataxia telangiectasia leads to your lymphomas and leukemias. Fanconi anemia leads to acute myeloid leukemias and so on. Similarly, other syndrome like xeroderma pigmentosa has shown that the children have higher incidence of skin carcinoma, especially the squamous cell carcinoma, as well as the oral squamous cell carcinoma and melanoma and basal cell carcinoma. Other numerical chromosomal abnormalities, the most common being the Down syndrome, as we all know, is more the children with Down syndrome are 20 to 30 times more risk of developing acute lymphoblastic leukemia. When to suspect a hereditary cancer syndrome? If the cancer is occurring in two or more relatives of the same side of the family, early age at diagnosis, multiple primary tumors, bilateral and multiple rare tumors, constellation tumors with specific cancer syndrome, evidence of autosomal dominant transmission and ancestry, then we will have to suspect it as a hereditary cancer syndrome. Age also plays an important role. There is a wide range of pediatric age group, 0 to 18 years. In some countries, it's 20 years. So some group of tumors are more common in the younger age group. That is, retinoblastoma, neuroblastoma tumor, neoplastic leukemias are most common in the younger age group. While in the adolescent age group, more common are the bone tumors, Hodgkin's lymphoma, gonadal germ tumors, non-Hodgkin's lymphoma, lymphoblastic leukemias, and epithelial tumors. Gender also plays an important role. Right? The males are most commonly prone for Hodgkin's lymphomas, the acute lymphoblastic, and females are most commonly have risk for thyroid carcinomas and malignant melanoma. Probably the gender-related factors or the hormonal factors and gender-related differences are the probable cause for this. Now, ethnical differences. The blacks or the Negro population have a decreased incidence of sympathetic nervous system bleedings and acute lymphoblastic leukemia. However, they have increased incidence for Burkitt's lymphoma and Bill's tumor. The South Asians have a decreased incidence of renal tumors and increased incidence of acute myeloid leukemias. Arabs have an increased incidence of bilateral retinoblastoma. The reason for this is not being found as yet. Some maternal factors are also important. For example, a mother aged more than 35 years with frequent miscarriage and the baby is a firstborn child will have acute lymphoblastic leukemias. Preterm birth will lead to germ cell tumors, low birth weight, hepatic tumors. Alcohol and tobacco used by the mother will lead to sympathetic nervous system tumors in the child. And diet, if the mother is consuming cured meat and there is increased risk for brain tumors. Diagnostic radiation in utero in the third trimester may lead to acute lymphoblastic leukemia. And the medications such as dihydrogenol medication was given for repeated miscarriages in the mother. So that will lead to vaginal and cervical clear cell adenocarcinomas in their daughters. Related, the father also play an important role. Those fathers working in the radiation field, they might transmit their mutated germ cell to their offspring and may lead to leukemia. Agriculture, the pesticide which have been exposure may lead to brain and CNS tumors as well as renal tumors. Paint solvents may lead to various tumors like this. So, paint solvent industry workers, welders, petroleum industry, paper and pulp mill industry workers, all of them can transmit their defective germline to their offspring. High fluoride exposure can lead to osteosarcoma, and tobacco smoking among the fathers may lead to neuroblastoma and acute lymphoblastic leukemias and acute myeloid leukemias in their children. There are some examples for environmental carcinogens and childhood cancers. Example, among the physical carcinogens, ionizing radiation, that is the diagnostic in vitro radiation or postnatal therapeutic radiation can cause cancers. And among the therapeutic radiation, thyroid carcinoma and mucoepidermal carcinoma are the most common ones to occur in children. Among non-ionizing radiations, that is the UV light exposure or magnetic radiation, brain cancer, leukemia, osteosarcoma, and thyroid cancers are most common. Among biologic carcinogens, Epstein-Barr virus can lead to Burkitt's lymphoma and Hodgkin's lymphoma. Hepatitis B virus may lead to liver cancer. HHV8 and HIV can lead to Kaposi sarcoma and non-Hodgkin's lymphoma. And human papilloma virus, which can be transmitted from mother to the child through the vaginal delivery, during the vaginal delivery, or due to sexual child abuse nowadays. They may have vaginal, cervical, oral, and oropharyngeal cancers. Chemicals such as phenytoin, chloramphenicol, alkylating agents, pesticides, metals, and plasticizers may also cause various cancers in the pediatric population. Tobacco, especially related to the oral cancer, leukemias, rhabdomyosarcomas, lymphomas, and lung cancer. So it's very important to avoid these as much as possible. Dietary factors have also been implicated. Consuming red meat or barbecue grilled fried meat, which is grilled or heated for more than 180 degrees Celsius, is known to contain nitrates or heterocyclic aromatic hydrocarbons, which might cause cancer. Then the potato chips, refined grains, less fiber diet, alcohol, acetaldehyde can cause oral and esophageal gastrointestinal tumors. Herbs, capsaicin in chilies is also thought to be one of the factors. Aflatoxin in peanut and peanut butter can cause liver cancer. Salted fish high in volatile nitrosamines can cause nasopharyngeal cancer. So there are incidences in the history which have linked environmental exposure to neoplasms. Examples are given here. This total cancer, which occurs most commonly in chimney sweepers. Then the atomic bomb survivors of Japan, Hiroshima and Nagasaki incident have led to leukemia and brain tumors. The survivors of Charbonneil accident have shown increased risk for thyroid carcinomas, especially the papillary thyroid carcinoma, leukemias, and brain tumors. Our own country, we had Imphal gas tragedy, and the survivors showed increased brain and brain tumors and other birth defects. So, how are pediatric neoplasms different from adult tumors? Are they really different, or are they really biologically distinct entities? We shall see. So, there is exceptional exposure among children. They have a unique exposure pattern in the sense that in the same environment, adults and children vary in exposure. They have a unique exposure. They breathe more air, they consume more food and more water and fluids in relation to their body weight compared to the adults. They have specific behavioral pattern, that is hand to mouth, object to mouth, crawling, outdoor exposure, which is not seen in adults. And they have also different nutritional patterns, such as the milk or drinking water. This is they have a very complex environment compared to the adults. So you have various hazards which are exposed, then the media through which they can get the carcinogens, they at various settings. They have all these activities which are a little different from compared with the adults, and they have various susceptibility pattern, and which I will be talking about, and the organs affected are also quite different. So there is exceptional susceptibility, inadequate absorption and distribution. In the sense, they have less acidic gastric pH, slower gastric emptying, less intestinal transit, hence incomplete or reduced absorption can occur. And they have increased membrane permeability when the toxins can enter the body, and increased transdermal absorption. So they have again increased absorption of the carcinogens. Rapid rate of growth and cell division, especially in bones, skin, testes, breast. So there is no time for DNA repair. So and further there is also incidence that these things can regress. The tumors can regress and they may undergo maturation at a later stage. Then there is immature metabolic pathway and detoxifying enzymes, especially the enzymes such as cytochrome enzymes are different in children compared to the adults. Immature immune system also make them prone for infections and carcinogens. And the remaining life expectancy is longer than the adults. There are critical windows of exposure in a child's physiology, which are not seen in the adult physiology. These are brief periods when a child is particularly vulnerable to a given exposure. And you can see that here it's a pre-conception, before conception, this is during conception, this is prenatal period, this is the postnatal period, and this is your childhood period. So the carcinogens, exposure to carcinogen can occur at any of the stage, but the perinatal stage, perinatal period is thought to be the time of greatest susceptibility to immunotoxic effects from the exposure to environmental substances, at which even small doses are sufficient to cause an enormous consequence. Getting cancer further depends on various factors such as the kind of carcinogen, amount of carcinogen, duration of exposure, frequency of exposure to chemical, mode of exposure, age and general health of the child exposed to the chemical. Exceptional outcome. The children have shown exceptional outcome compared to the adults. Since their response to therapy is good, the pharmacokinetics is different, long latency period, and hence chance for second malignant tumors are more. They have 98% of which cancer survivors suffer from a chronic health condition by the age of 45, which includes pulmonary, hearing, cardiac problems, and the child's growth, fertility, endocrine system is also affected, and the cognitive function is damaged. And child survivors are immunologically suppressed permanently. I have tried to compile few differences between the pediatric neoplasms and the adult neoplasms. Uh, Coming to the origin, if you see the origin, the pediatric neoplasms mainly arise from the deeper tissues such as the bone or the blood, and mostly the cancers are related to lymphohematopoietic, nervous system, sarcomas, etc. And they are more primitive or embryonal in histopathology. If you see, they are primitive, and they retain their growth potential and rapid growth. Apart from this, they have a tendency to regress as well as mature in future. While adult neoplasms are mostly epithelial in origin, are arising from either superficial epithelium or the glands or the ducts of the skin or the salivary glands and so on. Etiology mostly due to inherited mutations or as a not the pediatric cancers are not related to the lifestyle risk factors more commonly. And adult neoplasms occur due to cumulative effects of aging and long-term exposure to carcinogens, and they are also related to lifestyle risk factors. Exposure. In children, there is involuntary exposure. They are powerless and they must rely on adults to protect them from environmental carcinogens. While in adults, voluntary exposure is there and they can decide for themselves. So they are largely preventable. The pre-malignant stage, it doesn't is not recognized very commonly in pediatric cancers. However, with the changing behavior, with the example like smokeless tobacco you mentioned, the more and more pediatric pre-malignant things are seen in the early cavities, such as oral submucous fibrosis and so on. And this pre-malignant state can be easily recognized in adults. The incidence of pediatric cancers is very rare, but in adults it is more common. The diagnosis is often incidental and when the child is undergoing routine investigations for other unrelated disorder, while in adults it is very common due to awareness and screening programs. The symptoms are very non-specific and may mimic many other diseases, while adults the symptoms are well defined. The critical windows of exposure do exist, as I explained earlier. They exist in children, while they are not no parallel timings seen in adult physiology. These critical windows of exposure uh, have a substantial effect on the developing tissues, the developing tissues that undergo substantial expansion during the organic formation, growth, and maturation. Dynamic developmental physiology. The physiology also varies in children and adults. That is, the more lymphoid tissues seen in the tonsils, adenoids, and cervical region compared to the adults, making it more prone. Then the brain tumors are mostly infratentorial in children, while brain tumors in the adults are mostly supratentorial. Then the late effects are organ toxicity. Because of the exposure of the developing tissues, they have a devastating effect. The cognitive function, growth, ability, endocrine function, all are hampered in children, while comparatively the adverse effects are less in adults. The second primary tumors are very common in the pediatric age group since there is a long latency period, while they are less common in the adult age group. Now, prevention is most unlikely and they depend on parents, while 80% are preventable in adult neoplasms. Chemotherapy. The chemotherapy is better tolerated in children compared to adults, and the tumors are more responsible for chemotherapy when compared to the adults. Radiotherapy. It is sparingly used in children because there is risk of getting tumors which are developing due to irradiation. They are more vulnerable than adults to the adverse effects of radiation compared to the adults. Screening and awareness is not commonly done, and hence the diagnosis is often delayed in case of pediatric age group compared to the adults. Metastasis. 80% of cases present metastasis at their initial presentation, and it is probably attributed to the rapid proliferation of cells as well as diagnostic delay. And mostly, distant metastasis is very common in pediatric neoplasms. However, in adult neoplasm, only 20% cases show metastasis at the initial presentation, and mostly the metastasis will be local or regional metastasis. So now coming to the clinical expression of a childhood cancer, how can it present? It may present as a mass or a symptom due to invasion or compression. It may present as a paraneoplastic symptom, a general symptom, or due to metastasis. So the International Childhood Cancer Organization has given acronym, childhood cancer acronym, for the as a early warning signs of childhood cancer. So this include unexplained fever more than 38 degrees Celsius, which is frequent, recurring, and it is not going due to in spite of taking antibiotics. Unexplained weight loss, sudden weight loss, more than 10% of body weight. Then fatigue, headache, and early morning headache, and tiredness, restlessness. They can all be non-specific symptoms. Eye changes, especially the white spot in the eye, which is called as leukorrhea, or strabismus, proptosis, or bulging eye, or changes periorbital bleeding spots, everything can also be seen. Apart from that, unexplained back bone, uh, swelling or lump in the jaws or in the oral cavity or the supraclavicular or the head and neck area, the cervical region, should also raise a suspicion. This supraclavicular lymphadenopathy should be taken very seriously and investigation should be. Apart from this, skin changes such as bruising or easy bruising without any trauma. Then skin rashes or petechial hemorrhages also should raise a suspicion. Uh, Melanoma or melanocytic changes, that is the pigmentation on the skin, or changes in the skin surface, as in case of basal cell carcinoma or melanomas, should also raise a suspicion. The lump in the there is a bone pain or swelling in the joint should also raise a suspicion. Abdominal swellings due to hepatomegaly, splenomegaly are also very common, and these tumors extend enormously. And these tumors should not be palpated very hardly because this capsule can rupture with the seed. These all warrant immediate investigations. Coming to the oral cavity as such, there are so many lesions presenting in the oral cavity, such as swelling, or a gingival growth, ulceration, bleeding, or chloromas, and simple malocclusion, or a different colored changes in the growth. Then you may have malocclusion and swelling. So all these tumors, they may also cause, enormous tumors may cause blockage of airway. They may lead to difficulty in breathing, difficulty in eating. So all these can cause enormous effects. So alert dentist or alert clinician should diagnose these conditions at a very early stage. Apart from these lesions, the lesions can also be seen post-treatment of pediatric cancers related, such as mucositis, xerostomia, radiation-induced caries, or mucoepidermal carcinoma due to the radiation, etc. There are certain endocrine symptoms which should raise suspicion, such as diabetes insipidus or growth arrest, as in case of craniopharyngioma, supercellular tumors of pituitary gland, and histiocytosis. Precocious puberty, as in case of adrenal CNS tumors, rhabdomyosarcoma, and HCG secreting germ cell tumors, or delayed puberty, as in case of pituitary tumors. Paraneoplastic syndromes can also be associated with childhood cancer. For example, neuroblastoma shows catecholamine hypersecretion related symptoms such as sweating, flushing, hypertension, failure, and palpitation. There is also one more rapid chaotic eye movement with involuntary jerking muscle movements are also seen, and this should raise suspicion of neuroblastoma. In hypercalcemia can be seen in leukemia. Apart from that, rheumatic symptoms such as musculoskeletal pains, fever, fatigue, arthritis, hepatosplenomegaly, back pain, and weight loss should raise a suspicion of leukemia, lymphoma, and aging cell. So, what is the diagnostic approach? Most of the clinical presentations is non-specific, and these are often detected incidentally, and hence and early diagnosis is very crucial for the survival. So early stage disease equal excellent patient outcome, while advanced stage disease usually leads to poor outcomes. An alert parent and alert clinician play a very important role. The diagnostic approach should be systematic and thorough. So it's usually the diagnostic approach starts with the history taking, the history about the family, any cancers in the family or anyone suffering is very important. Then the mother is the one from whom we usually elicit the history regarding whether there was a past exposure to carcinogen, what is the medical condition of the child, did he have any medication, or what diet he used to have, or what is any infection or symptoms in the recently. Many a times the mothers may not remember or relate some symptoms to the cancer. So it is very important to ask history very thoroughly. For the clinical examination, overall behavior of the child, was he very active? Was he involved in his normal activities? Or in the past few days, was he lethargic? So those things are also important. Apart from that, specific to the lesion, such as a palpable mass, pain, lymphadenopathy, all this is again important. I would like to stress here that no clinical test replaces a good clinical history and a good careful physical examination. Appropriate basic investigation should be performed without any delay. This is a very busy slide. You see that the diagnostic workshop, it begins with a thorough physical examination, clinical examination, and followed by few tests such as blood tests. Blood tests, simple differential count, total blood count, reticulocyte count, ESR, peripheral smear studies can be diagnostic many a times. The lumps, the FNAC, followed by cytology, are also important. They can be, you can do a biopsy with the histopathology examination. If there is certain difficulty, you have many IHC markers as adjuvants, which can help us to arrive at the diagnosis. And we also have imaging techniques such as the simple occlusal radiographs, CT scans, MRIs, PET scans, and so on. And the cerebrospinal tap or the lumbar tap, okay, spinal taps are also available, or bone marrow biopsy is also available to arrive at a proper diagnosis. There are some serum markers which help us to detect pediatric cancers, like VMA in neuroblastoma, serum alpha fetal protein hematoblastoma, beta HCG is in leukemia, lymphomas, and head and neck cancers, and so on. Lacto dehydrase as in case of lymphomas, and beta 2 microglobulin as in lymphomas and mesopharyngeal carcinomas and myeloma. Chroma granule A as in case of neuroblastoma, neuron specific kinase as in case of neuroblastoma and rhabdomyosarcoma. There is also challenges regarding these serum markers. It is very difficult to establish standard concentration since due to the rarity of the tumors. And above that, obtaining a biological sample is difficult because there are difficulties accessing the venous tool, as well as due to some ethical and emotional concerns. Salivary markers may be they are upcoming in the recent times. Salivary genomics, proteomics, transcriptomics, metabolics, and microbiome-based discoveries are again very at the inception stage, and they may probably be a good alternative for the serum markers as they are non-invasive. And a few examples are DNA detection of all these viruses can lead to the diagnosis of cancers, respiratory cancers. Genetic analysis of the mutated genes can be done. There are so many genes which are attributed to childhood cancer. These can be genetically analyzed. The next generation sequencing is also there, so we can do the genetic analysis also. Further, parents who have hereditary syndromes, if they do not want to transmit their mutated gene to their offsprings, they can go for IVF. And in the IVF, before implanting the embryo in the womb, certain pre-implantation genetic diagnosis is available. However, there are some disadvantages related to it. It doesn't guarantee that 100% the genetic mutations cannot are transmitted, and there is very costly and there is ethical issue. What are the reasons for the diagnostic delay in childhood cancer? There are non-specific symptoms. Most of the time, the parents neglect. If the parents take to the doctors, doctors might think that it is a simple fever, or they might just give some antibiotics and send. So, non-specific symptoms. Lack of awareness among parents and public is huge. So that has to be overcome. Limited knowledge and insufficient skills of the healthcare practitioners. Lack of efficient medical infrastructure and diagnostic facilities. This very much holds good in the Indian scenario, where most of the pediatric cancer institutes are located in urban cities and the metropolitan cities, and the rural population do not have access. Largely, there is no diagnostic setup or treatment setup in the rural areas. Less rigorous health checkups or screening in children is done usually, and there are also financial constraints and social issues. What is the prevention? Prevention can be done at three stages: primary prevention, secondary prevention, and tertiary prevention. Primary prevention is to reduce the risk factors. We don't know what are the risk factors, but as a whole, we can try to reduce the risk factors. They promote immunization. Immunization for hepatitis B or HPV is available. Then breastfeeding, the immunoglobulins may help in protection. Folic acid supplements and so on. Preconception counseling on healthy lifestyles for parents to be, and also health education and information about healthy lifestyles in schools have to be implemented. Awareness about the childhood cancers among public and all health professionals has to be implemented. And secondary prevention is done for the early detection of cancer to decrease the advancement of the cancer to the advanced stage. This will reduce the cancer mortality. Also, medical treatment on regular basis should be implicated. Screening programs, especially for the risk group populations, such as children of belonging to family with hereditary family cancer syndromes, have to be screened at a regular basis. Further, tertiary prevention is done to prevent the second malignancy development in childhood cancer survivors. So, children are not alone in their fight against cancer. A whole team of professionals is with them. It includes many workers, such as oncologists, physician, dentist, dermatologist, pulmonologist, and so on. So, we all have to work together. Interdisciplinary approach is very, very important. What are the challenges in the pediatric oncology research? There is limited information and limited studies, biological studies about pediatric tumors because of their rarity. And further, obtaining an accurate information and fast exposure from their parents is very, very difficult. And the age group for the pediatric population varies enormously from region to region. It starts from 0 to 12. The upper limit is usually varying in different countries. Further, clinical human trials may be difficult in this population. Uh, Clinical translational research is also not representative because mostly the animal studies are done, and the animal studies, especially in adult animals, it is done. So the clinical translational research may not be representative. Challenges for effective standard oncology treatment and technical difficulties are also there. Social, emotional, and ethical concerns are also there. And there is lack of cancer registry for pediatric cases as yet, especially in the rural areas, especially in the Indian scenario. So to conclude, like to say that child is a unique individual. He or she is not a miniature, not a little given man or woman. Pediatric cancers are rare and vary from that of adults in various aspects like clinical presentation, behavior, and survival rates. High level of suspicion is essential uh, for early diagnosis and management. So, in the end, I would like to say that pediatric neoplasms are definitely distinct biological entities. Thank you.
Thank you, Nandini. That was a wonderful presentation. And yes, very, very well done, very in detail. And you just mentioned Ram Manohar sir's name, and you will be happy to know that he's watching. He's been watching right from the beginning. Hello, sir, and
Thank
it's
you.
great to have you here. And so has Sitwa Mondal sir also been watching,
Oh,
and also he has some
thank you so
questions
much,
for
sir.
you. Anyway, I'll start first with a question that had been sent earlier. Okay,
Okay.
and it's we have so many that cases of papillomas in children,
Yes. Yes.
although we don't seem to have that many in adults. So what is the
We do
case in
have,
that?
ma'am. We do have. Ma'am, actually, squamous papillomas in our present institute also, we have seen many cases actually. Probably they are related to the HPV only. Okay, maybe we need to ask about the sexual, behavior or abuse of the child, and we also have to see whether that maternal HPV has been transmitted to the child during the vaginal delivery. So that is also one factor which is said probably that it would affect, it would cause the squamous papillomas in the pediatric cases. We need to be vigilant.
So now that you have answered that, I shall get on with every other questions. Mondal sir is asking you why metastasis is more common in pediatric tumors.
Sir, because of probably the way there's rapid growth and proliferation occurs. So they have easy access to the blood vessels, and most of them are blood vessel origin. Most of them are blood vessel origin. So that could be one of the reasons.
And we have someone was asking you now show the number of symptoms, I think, on those pediatric cases, the combined slide with a number of pictures. So you have a question, are all these common for all the tumors or they are specific?
No, no, they are specific for individual tumors. What is that is, I have already told in the beginning of my presentation that I will not be dealing with individual lesions separately. So as a whole, I have combined them and I have presented here because it's different for different tumors.
So basically,
If
they're
you
just
want me
giving
to
you an
explain,
indicator of what all to look
yes,
for.
yes.
Right.
So if you want to know which tumor causes which symptom, kindly you can mail me, which I will be very happy to share with the data which I have collected.
Yes. Okay. And then I think Mondal sir at one point was commenting, why not call them bone tumors instead of, what was it, heart tissue tumors?
Yes, ma'am. You can call them as bone tumors as
Bone
well.
tumors.
But bone in the sense we have jaws also, so we can call them
Yes.
jaw tumors in the head and neck, and that would be
Right.
more specific for a head and neck area. While in the rest of the area, you may call them as bone tumors. So instead of that, I have put it in the common heading as heart tissue tumors.
Yes, absolutely
So
right.
that was my
Right.
point, sir.
Yes. And of course, this is a little out of our field, but Mondal sir has asked, is there a role of vaccines in prevention of cervical cancers in children? This is
Actually, there
like
have been
out of our
trials,
area.
ma'am, for HPV. Actually, there are trials, and it is indicated that the girls, especially of 12 to 13 years of age, are recommended for HPV vaccine, since we are seeing the increase in the incidence of HPV related tumors, especially the oropharyngeal tumors in nowadays. So it is recommended, but how effective they are, we don't know yet. Even
And I
HPV
guess it
vaccine
will
is
be
also,
different.
yes, ma'am. HPV vaccine, I found one article where HPV vaccine for boys also is recommended. So
Yes.
I'll have to get into depth of it further
Yes.
because
Yeah, and I guess it's a little different population to population, and things are a little different. Although in the long run, yes, if we can get the population to agree to something like this, I think our population is not going to be very happy about it. And it could be preventive, I guess. When we are thinking prevention, it
Yes.
should work. But we are some distance
And
from
for
there.
yeah, hepatitis B vaccination is also very important to prevent the liver cancer.
Yes.
So that is
Yes,
also being
correct.
implemented.
That is
So
another
those
thing,
are the
yes.
two vaccines.
Against infections, that can definitely make a difference. I don't think there are any more questions. Yes, Mondal sir has rightly added that most metastases are more common also, possibly because their majority are sarcomas, and obviously there is metastasis is
Yes, ma'am.
always there.
Thank you so
So
much, Mondal sir. I would like to thank Mondal sir very much that he's watching me as well. Add many. He's a knowledge of pediatric pathology, ma'am. Thank you so much, sir, for attending this webinar. Thank you so much.
very nice of him to attend and to comment. Definitely, interaction and exchange of ideas is what
Yes.
science is all about. I guess we have come to the point where I shall give you your certificate of appreciation on behalf of me.
Thank
Yes, Oral Pathology
you.
India. Thank you so much, Nandini, for your time, for your
Thank you
efforts, for
so
your
much for the
sharing your
honor.
knowledge.
Ma'am,
Yes,
thank you so
thank
much
you.
for the honor and privilege of letting me to present in your blog. And I really
Oh,
am felt very honored. Thank you so much, ma'am. Thank you.
yeah, this was something that had to happen. It's been waiting. I've been waiting to hear the result of so many years of your work. So thank you,
Thank you,
Nandini.
ma'am.
Thank you,
Thank you, ma'am.
Bhavna.
Thank you, Bhavna. Thank you so much.
And thank you everyone for watching and for supporting this. If you have liked whatever you have seen so far, please, and if this is your first time, please remember to subscribe to the channel so we can continue doing this, and have a lovely day.